Hi, my name is Antonio Mendez, and I would like to thank the organization of this meeting for inviting me to present this topic with you. It is femtosecond laser versus microkeratome in LASIK. We are currently using the ML7 MedLogix microkeratome. This microkeratome was made to make a temporal hinge, but just by turning the vacuum ring, you are able to do either a superior or a nasal hinge also. This suction ring also makes it possible to be used without a lid speculum, especially for those patients with a small lid aperture. This equipment uses pre-calibrated blades, which gives us a true thickness cut. These pre-calibrated blades come in plano, -10 and +10, +20, -20, and +30 and -30 microns. So depending on the microkeratome head, we can add or subtract 10 microns, 20 microns, 30 microns to give the perfect flap. Now, in regards to suction control, this also plays a game in the thickness of the cornea. The more vacuum, the thicker the flap is going to be. The less vacuum, the thinner that flap is going to be. This has to do with the compression of the cornea on the plate of the head of the microkeratome. So together with the vacuum control, you can really fine tune every single cut you make with this microkeratome. The suction ring is the one in charge to give us the diameter of the flap. The fenestration in each of these suction rings is different. It goes from 8.5, 9, and 9.5. The smallest diameter will protrude less cornea and thus giving us a smaller diameter flap. As the cornea grows flatter, it is important to use the larger fenestrated vacuum rings. The ML7 has two motors. One is for the blade oscillation, and the other motor is in charge of advancing the head over the cornea. Because in other equipments where only one motor is used, as the advancement of the microkeratome head goes and slows down, the oscillation blade also slows down. As a consequence, you get a deeper and irregular cut. This does not happen with this microkeratome. This is very, very important. This feature produces a very homogeneous flap and stromal bed. And we also have access to the Visumax Femtosecond laser. It's from Carl Zeiss Meditech, Jena, Germany. These interfaces that the Visumax uses have a curved lens, and this makes it very, very comfortable for the patient and for the docking. There are three sizes, small, medium, and large, and this will depend on how large you want the diameter of that flap. And the diameter and the thickness of the flap is controlled, everything is controlled by software. This interface also has a very low suction that permits to hold on to the cornea or to the limbus, depending on the size. So the patient really does not get to lose sight of the fixation light. The hinge position can also be software controlled, and we can place it superiorly, nasally, or temporally. It's very straightforward. It's very easy to use. The all the software and all the controls are very accessible, and it's very easy. For hyperopic treatments, I always prefer a temporal hinge. We decided to start a small study where we would measure the thickness of the flap, the diameter of the flap, how smooth the stromal bed was, and how much time we took for each procedure. We checked the visual acuity of our patients and what type of complications we had with either of those equipments. In regards to the thickness of the flap, I always prefer to use 100 microns. We use the NIDEC OCT after a month of the surgery to measure the thickness of the flap. I was very impressed to find out that there was no significant statistical difference between a flap made with the ML7 or the Visumax femtosecond laser. In fact, after a month, it is almost impossible to determine which flap was made with a microkeratome or with the femtosecond laser. The diameter, since all of the ablations were programmed to a maximum of 6.5 millimeter in diameter, all flaps were made to be at least 8.5 millimeters or larger. The Topcon 7D sleek lamp was used, and the 8.5 millimeter slit was placed over the flap horizontally and vertically to determine if the flap was greater or smaller. In all cases, the flap was greater than 8.5. In regards to the time of the procedure, this was very interesting. And here in Baja California, here in Tijuana, we do very high volume laser refractive treatments. All cases were bilateral. Both eyes were treated using the same technique. Time was measured since the placement of the lid speculum of the first eye until the lid speculum was removed on the second eye. The average time when we're using the femto LASIK, it was 18 minutes, 13 seconds with a 45 seconds standard deviation. With the microkeratome, the ML7, the average time was 10 minutes and 51 seconds with a standard deviation of 52 seconds. And we were very surprised because almost double the time it took using the femtosecond laser to do both eyes as compared with the microkeratome. The time of the procedure is very important, especially if you're handling volume. If you're doing almost double the time to do one case, well, maybe the microkeratome would be the best solution. In regards to the smoothness, we took photographs of the stromal bed using the same video system that is integrated with the MEL 90 from Carl Zeiss, the excimer laser. It is very easy to see how much light scatter from the stromal bed of the Visumax as opposed to when we use the microkeratome. We were also very surprised when we analyzed visual recovery. We took into account the binocular best corrected visual acuity, and we compared how many patients were able to reach this after 20 minutes the following day, 2 weeks after the procedure, and 1 month after the procedure. Well, patients that had femto LASIK, only 22% of the patients after 20 minutes were able to reach their best corrected visual acuity, as opposed to 67% when the microkeratome was used. The following day, we measured again their vision, binocular vision, and 83% of the femtosecond LASIK were able to reach their best corrected binocular visual acuity, and 98% in the cases of the microkeratome. After 2 weeks and 1 month, all patients had reached their pre-op binocular best corrected visual acuity. No major complications occurred in our patients in this study. The most common complication was a moved flap, and this flap was repositioned at the moment it was diagnosed. All cases of epithelium in the interface, when this occurred, was due to LASIK enhancement, and no statistical difference was found in either of these groups. No correlation was found with the residual refraction in either of these groups. Thank you again for your kind invitation to participate in this annual Congress, and I hope to be with you very, very soon.